Second, welcome to Dr. Prabhakar. Thank you for your patience, and we look forward to hearing your story.
So thank you, and thank you for sorting out the IT problem. All of you have seen this slide, so I don't have to talk much about this. The fact is that in most of the LMICs, the big problem is prevention policies are not in place in most countries. There's huge disparities in care all across LMICs, and even within high-income countries, there's huge disparities in care. There's lack of simple and essential drugs in many parts of the world, and there's gaps between best practices and actual delivery. Now, they have been fed with this information that this management of hypertension, management of lipids, and all that is a pharmaceutical industry issue. They're trying to get more and more people into treatment. This is the kind of information they have, and they really think it's not required. So we really need to do something. And I think we need to think in a very different paradigm, because most of us think of behavior change as a very simple issue. Behavior change, we think, is providing information to people and they change their attitudes. But the pathway to health promotion is three things. We are focusing largely on the I know component, trying to provide information to people. But what is required is to motivate them so that they can say that I want, and provide them enough skills so that they can say I can, and they can say that they will act and teach others, and that there can be a social diffusion of things there. But most important is to provide an enabling environment. If you are asking people to walk and there are no sidewalks to walk, there are no parks to walk, where are people going to walk? So we really require an enabling environment. So we saw that mass screening doesn't work, so we need to move on to opportunistic screening and use some disruptive thinking to improve opportunistic thinking. So I think the four things that can really improve hypertension care is linking community to the health system, improving access, availability, and distribution of drugs and care, address human resources shortages, and quality improvement, team-based care, and several others. We have worked in task shifting and using digital health over the last 10 years and have done worked in several areas that include surveys, linking community to community primary and secondary and tertiary care, content development for texting and follow-up reminders, clinical decision support system, integration with point-of-care device, integration to the national electronic health record system, and international and national deployment. And we work in 9 countries. And I'm just going to present a brief snapshot of that. The question that you might ask is, why do we need to do task shifting and task sharing? In my part of the world, there is a high patient load. As a cardiologist a few years back, Karthik is here, he will also confirm that in a single OPD, we see something like 60 to 70 patients over a 3 hours period. There's hardly any time. So patients need that time, and therefore some of the tasks of the doctors can be shared by nurse practitioners or community health workers, which really reduces the time for the doctors. The second problem that we have is there is an emphasis on curative care or prevention. And we know from HIV, the world, that there's a huge amount of experience in task shifting and task sharing, and can we use some of those in improving management of hypertension, diabetes, cardiovascular diseases, and other chronic diseases. The second thing is we pair them with ML technologies, we pair them with the IT-based digital technologies. And Eric Topol published a study a few years back, and he said for the consumers, there's improved convenience, more active engagement in self-care, and greater personalization. For clinicians, the demands on time and is addressed, and there's a refocus on the art of medicine. There's a potential to change every aspect of the healthcare environment, delivering better outcomes and substantially lower costs. In fact, McKinsey said, did an analysis and said, healthcare costs over a 10-year period will be reduced by $20 billion if you use ML technologies, and that's quite a bit of power. Now the question is, we didn't have real-world clinical trial evidence to provide a roadmap for implementation of this. So we designed several programs over the last 10 years, conducted trials, randomized controlled trials in tertiary care, at a community level in primary care. We also looked at the integrated care, identifying one disease and caring for 5 conditions, and several other mechanisms that we did. As Sonia said, you have disappointments when you have neutral trials, but there were lots of positive trials. Integrated care didn't turn out the way we wanted to, but we could control high blood pressure and diabetes and reduce the risk. Now the question then comes up is to how to scale that up. So let me summarize what the system that we developed. It's an Android app. It runs on tabs. It's interoperable in multiple systems, and it conforms to existing digital standards. We developed a clinical decision support system for screening and management. And in the back end, there are 2,500 clinical management scenarios. Like, for example, a patient walks in, a 55-year-old man walks in, has blood pressure of 160/100, has no other risk factors. The decision support system gives a treatment plan. So it's kind of personalized management plan for that patient. The conditions that we have worked on includes hypertension, dyslipidemia, chronic obstructive lung disease, asthma, depression, tobacco, and alcohol. And currently we are working in care of gestational diabetes and pregnancy-induced hypertension. It stores patient data in electronic format. Now we have scaled it up by having a statewide implementation. There are 2 states in India, the northeast of the country, and we have implemented that all across 2 states. And finally, we are doing a pilot to integrate the module with the national portal of the Government of India. And we've also done some international work in terms of creating an MPIN package for the WHO, and that's being implemented in Maldives. So it also has potential for big data and artificial intelligence. Just to give a small perspective, then the next thing that you ask is, you do research, you have your research staff, it might work. Will it work with the usual staff? And that's what we try to do in Himachal Pradesh, where you can see that the number of detections of hypertension and diabetes was close to 50%. If not for this system, 50% of these patients who are visiting these clinics would not have been diagnosed to have diabetes or hypertension. The second thing was there's a huge drop in blood pressure as well as in blood sugar, and that persisted for 18 months. So clearly, task shifting and digital technologies are powerful. It can be scalable, it is feasible, and we can use local health systems to work using these systems. But what are the limitations? One is we have just worked with the government system. In India, private healthcare provides almost 70% of healthcare in the country, so we need to integrate private healthcare. There's insufficient continuum of care model, so we need to look at the whole spectrum of continuum of care. There are inadequate referral pathways, inadequate thresholds and linkages, and there's a need for management advisories for different levels of care and health institutions. Now the question is, how do we redesign the health system? And for us in India, there is a big opportunity because there's a government decision to implement universal screening of 5 priority non-communicable diseases. There's an increasing focus on non-communicable diseases in primary healthcare settings. And the state of Punjab has been identified as among the states with the highest diabetes and hypertension prevalence. So we thought we will conduct a pilot in a district of Punjab, where we used all the experiences that we had learned by using digital technologies and by task shifting, and implement a program so that we can establish referral linkages, look at clinical handover pathways, and see at a community level whether we can impact hypertension and diabetes and improve care, especially access to individuals for management of hypertension and diabetes. So this is a path which we have followed from primary research to scale up to policy making. And I think that's, if we have to make a big difference, we have to work with policymakers and really work on big scale. The second part of the program has been addressing human resource shortages, because countries like India and other LMICs have been largely focused on infectious diseases, nutritional diseases of undernutrition, and several of the pre-transitional diseases. Most of the undergraduate training that is provided to doctors has been focused on these diseases. There's been very little training on chronic diseases, and physicians are very reticent to manage chronic disease, and they refer these patients to specialists. And given the fact that we have a very small number of specialists, there was a need to train primary care physicians on scale, and we developed multiple programs for multiple chronic diseases. And for hypertension, we have developed one of the programs which has been scaled up to in Rwanda, Kenya, Sudan, and Mozambique. We plan to extend this to Sri Lanka and Nepal, and we are working on an e-learning course along with American Heart Association to do it all across the world. So these courses are very popular. These are done on a designated Sunday all over India. We have 500 training centers all across India, and this is conducted in a standardized fashion. Dr. Yusuf has been very helpful in developing the cardiovascular disease course, which is also likely to be scaled up. The last point I want to make in terms of hypertension is we need to look at upstream determinants. Air pollution and walkability is an example, and it can make a big change. We have been funded for a program called the GeoHealth program by NIH. The main objective of this program is to link up particulate matter 2.5 levels to incident cardiovascular risk factors and outcomes in Delhi and the city of Chennai. The idea was to develop an exposure model to predict daily PM2.5 concentration at 1 square kilometer spatial resolution in Delhi. Currently, most of the monitors will look at 10 square kilometer spatial resolution, and that actually dilutes the relationship. So you need to get into fine grids of 1 kilometer to 1 kilometer. So we created a total of 1,635 grids over a 7-year period, and we have data on air pollution of every day from 2010 to 2016 for 2,557 days. There are close to 4 million observations, and in an area of 4,500 square kilometer. Unlike most other studies, we use multiple sources to get the PM2.5 levels. We measure pollutants, we use satellite data, we use emission inventories, we use weather data, because if you have a strong wind, the PM2.5 can be blown away. So we use day-to-day weather data. We regress for the land use, and using all of this and using a machine learning technique, we can predict every day what the PM2.5 level will be in that region. Given that we have had 4 blood pressure measurements in our cohort, we had the opportunity to link PM2.5 level acutely as well as chronically, to also look at the incidence of hypertension. This is the kind of picture we get, which is very useful to policymakers. As you see, as we reach October, things become red in color, which means the PM2.5 levels are extremely high. We also looked at neighborhood systolic blood pressure, road traffic in Delhi, and you see the larger dots means higher blood pressure with huge traffic intersections. And you can look at the walkability index in Delhi, which is very, very red, which means obviously there are very few places to walk in Delhi. Now, putting this all together, we evaluated close to 3,300 individuals from 2,500 households with 3 BP measurements over 7 years. And we used a longitudinal mixed effects model adjusted for several demographic variables, risk factors, road proximity, and accounting for individuals clustered within each of these groups. So for every 25 microgram increase of PM2.5, the blood pressure was higher by 3.5 to 5 millimeters, depending on BMI. There was an interaction with BMI. So decreasing annual PM2.5 by 25 microgram can potentially decrease blood pressure by 2.98. We use several of these parameters to model this data. And as you can see, on an average, currently it's around 125 microgram per year in Delhi. And if you reduce it by 20, the prevalence of hypertension can come down by 5%. And if you attain the national standards, which is a little difficult, there can be a 15% reduction. That's the power of looking at upstream determinants, and therefore we should look at that. So this is the story of hypertension. Now let me stargaze and look at the future. I'm not going to dream too much. What are the new frontiers and innovations that we need to look at? We need to understand the underlying mechanisms of the disease, particularly in terms of ethnicity and context. We need to address comorbidities. I think we need to move from individual to family level or group level interventions. We need to develop new modeling techniques and new research designs, develop and evaluate new metrics of measurement, use technology for addressing many of the challenges, and we need to address new challenges, particularly air pollution, climate change, food systems, and the environment. Now let's take the case of diabetes. If you do an ecological comparison, the overweight and obesity as defined by BMI greater than 25 in the United States is close to 2/3. 60% of the population have BMI greater than 25. These are real data. In India, BMI greater than 25 is close to 13%, And in China, BMI greater than 25 is close to 33%. Remarkably, the diabetes prevalence is the same across all these countries. So the question is, the paradigm of overweight, insulin resistance, is that the real cause? Are there other reasons for increased propensity to diabetes? And there could be multiple reasons. Early results from our study, which is looking at non-alcoholic fatty liver disease amongst Indians, appear to suggest that it's extremely high. Yet close to a third of people have non-alcoholic fatty liver disease, even with average BMI of 23 to 24. The second problem is we have lower beta cell function and capacity, whether it's because of undernutrition during childhood, whether it's because of pesticides, we really do not know. And these are some of the future questions that we need to answer. The second is, there is a high concordance of non-communicable disease risk factors or non-communicable diseases in a family. It's not that aggregation of risk factors are there. If in a family there's a person with hypertension, the chances of having obesity is high. If there is an individual with diabetes in a family, there could be another individual with depression. So there is actually aggregation of non-communicable disease risk factors. So the question is whether we should do family level interventions rather than individual level intervention, and that's one area that we are working on. The next is to look at data gaps in diet and food systems, and we need new approaches. New metrics are needed to measure diet quality and sufficiency, as well as food system efficiency and sustainability. Improvements are needed in 5 areas. Improving data on actual food intake, which is currently lacking in most countries of the world. Agreement on how to measure diet quality. Metrics that measure women's role in defining dietary choices. Metrics to measure the food environment within which dietary choices are made. And metrics to measure the health of food systems overall. Because there's a huge amount of water depletion in a country like India. The red areas suggest more than 50% groundwater depletion. And it has been shown that fruits and vegetables growth is, fruit and vegetable growth is decreased by 50%. But more importantly, not only that there is a decrease, there's a 25% lower beta carotene concentration in these fruits which are grown in these water depleted areas. So we need to look at the environment very, very closely. We are living in an interlinked world. Industrial scale livestock breeding leads to obesity, cardiovascular disease, and cancer. In addition, it results in climate change. There is a food crisis because of grain diversion, and there is pandemics. So we need to address this in an integrated fashion. And health sector can play a very important role because it's a key contributor to greenhouse gases. In fact, it's estimated that in many of the developed countries, 10% of the greenhouse gases is contributed by the health system. And it's also a mitigator of these environmental health hazards. So we are looking at strengthening capacity of research, communications, and advocacy in air pollution. And there is preliminary evidence that greening of hospitals improve health outcomes. So we have created a health and environmental leadership platform, which has more than 7,000 institutions, which are trying to improve their institutions. We're also looking at using hospitals for air pollution monitoring in the tier 2 and tier 3 cities of India because we don't have enough monitors to look at this. And we are educating doctors about the role of air pollution and climate change. So the whole idea is to create climate smart and climate resilient hospitals. There is also need for technological innovations to decrease disparities in healthcare, to improve surveillance system, to improve diagnostics using point-of-care devices, to improve drugs, which people are going to talk about, improve drug availability and drug distribution using some of the new technologies such as the blockchain technology, improving access through virtual polyclinics, and integrating care within chronic disease and between chronic disease and other diseases. We have developed a Wi-Fi enabled device that works on an Android platform with various sensors for frontline workers, and it can do multiple tests on a single platform, and this is being rolled out. So ultimately, to reduce gaps in prevention treatment, we need to look at research from multiple angles. We have done remarkably well in terms of developing the scientific credibility. But in terms of financial feasibility, you would be surprised to know that the Nobel Prize was given for using randomized controlled trial in economic research. So in looking at financial feasibility is an important thing. Looking at operational stability, and that needs health systems research, and looking at political viability needs social sciences research. So this needs multidisciplinarity, disruptive innovations, and attention to policy and upstream determinants. So this is all I wanted to talk. This is a pictogram of the people with whom I collaborate. I'm going to use the French term merci to thank all of them, but please mercy if I missed out some. And I have to thank my family, as well as my extended family and my mentors, and who have really shaped this amount of work. And I will leave you with 2 quotes, which shows that there's a lot of work that needs to be done, but I'm really positive that we can